Hopefully, you will leave tonight with information that will make your lives and the people you love better. That's the reason we're doing this. A little bit about me, because I see a lot of new faces. Family practitioner by training many years ago. Been doing integrative medicine for the last 20 of those 35 years of MD work. And life has never been better. At 61, I only wish that I could keep going another 30. Maybe I will. But it's been incredibly empowering to realize that everything I learned in residency was just really an entry point where knowledge would begin and not where knowledge would end. So I call myself a recovering MD because I realized at age 45 I knew nothing. And I went back to school and I started taking every class, course, summit, podcast, webinar, whatever they were called back then, on food, nutrition, mind, body, medicine, detox, and all of these crazy things, which led me to being asked and honored by the Institute for Functional Medicine to teach their advanced practice hormone module with a team of amazing people, likes of which you might know. Mark Hyman is on the faculty with me the last 11 years, and we've been having a great time educating a world of people that have lost hope in our traditional way of looking at things. When you can kind of take a step back and say, how did I get here? This doesn't make sense. I felt good then and now I don't. So a little bit about me. The rest of the night's going to be about you guys. We're going to talk probably more of a formal presentation, as formal as it's going to get. There's no slides intentionally because slides are distracting and boring. And we can be a little bit more unstructured without them, for about an hour. And then the last half hour is for Q&A. And literally anything you want to goes with thyroid. So I have kind of a format that we did last time that worked well, and I'm going to try that again, where we start off with basically 3 or 4 parts to this presentation. The first being centered around symptoms, signs and symptoms. A lot of you, it'll be review. Some of you, it might be, oh, I didn't know that was part of that angle of thyroid. We're going to move into what an appropriate lab assessment and workup might look like as part 2. Part 3, we want to move into some of the differences, nuances with medication. And then lastly, we can talk a little bit about what to expect and how to follow these things up, not just with symptoms, but the kinds of labs that we're looking at for optimal thyroid, not just in the normal reference range. A little bit about the normal reference range before we start, in case I forget, because it's that important. Reference ranges are obtained by random sampling of a given population. And when I look at a reference range for certain things like thyroid, it has a very narrow window for pre-T3, which is the active thyroid that's made by T4. T4 does really very little. It's a prohormone made by your thyroid gland. Very little T3 is actually made by your thyroid. Most of it's made by peripheral conversion from T4 to T3. And therein lies the subject and the problem of the whole discussion tonight. Many people aren't very good at converting T4 to T3. And there's a lot of reasons why we think that this might be happening. But it really begs the question of, is our current standard of care, the way we assess thyroid, adequate? And I'm hoping by the end of the night, I will have caused you to think enough and a little bit more to maybe challenge that traditional thinking. I know it's changed my life as a practitioner, and I've seen it change the lives of hundreds of people thinking a little differently, a little outside the box. So reference ranges are walking into Walmart. I'm going to pick on Walmart tonight. I think I said McDonald's last time, but let's just pick any franchise chain store and walk into fill in the blank America, and you look around, and I'm thinking, is this the optimal lab range that I want to base my references on, or are these folks that maybe aren't healthy and are missing an optimal healthy range? And my answer to that is, I don't necessarily want to look like everybody else anymore. I don't want to feel like everybody else. And I certainly don't want to be on as many medications as they are when I'm 70. And so reference ranges are there. They're basically set by standard deviations above and below a mean, and you've got cut points. And if you're here at the very end, you're still in the normal, but you might be really suffering. I never wanted a D in a college class and call it passing. I just wouldn't accept that. And I don't expect my patients to walk around through life in the bottom tertile or quartile of a reference range and say you're normal. Especially when I look at where they're getting the normals from, which are less than optimal health. So we named our company Optimal, FMI, Center for Optimal Health, literally for a reason. We want optimal levels and optimal health, not just status quo health. So a little bit about symptoms. How many of you have heard that hypothyroidism causes fatigue? Show of hands. Yeah, everybody knows. I think everybody knows that. How many of you heard that hyperthyroidism causes fatigue? This one maybe not as common, right? Everyone that hears about Graves' disease, which is overactive thyroid, it's autoimmune. There's antibodies that you can measure for this thing. Thinks about racing hearts, not being able to sleep, tremor, anxiety, loose bowels, all these symptoms of an overactive metabolism, losing weight. When in fact, when your metabolism is on overdrive, going 100 miles an hour with your hair on fire for too long, you start to crash and you actually get really, really fatigued. So we had a new thyroid patient present 2 weeks ago to my clinic in raging what we call thyroid storm, which she had the fast heart rate. You know, she looked like she'd taken something illegal. She was really energetic. And as of last night, when I looked at her labs 3 weeks later, she's now completely crashed. She's hypothyroid. She's not making any thyroid at all. And her TSH is 60. Normal's like 0.5 to 2.5. So she's terribly hypothyroid. 3 weeks ago, she was having a hyperthyroid crisis, a storm. She was put on a medication that prevents T4 production, basically, methimazole, while she rode out the storm, and put on a beta blocker so her heart rate wouldn't be in the stratosphere. She didn't have Graves' antibodies. She had something we're going to spend a little bit more time talking about. The number one cause of hypothyroid, Hashimoto's, autoimmune thyroiditis, which starts off with antibodies that attack your thyroid gland and cause damage to it, release stored T4 hormone, which gives you a hyperthyroid crisis initially. It burns out and initially goes hypo. So hypo that started off as a presentation of looking like Graves. So hyperthyroidism, hypothyroidism, these are the terms that you hear. A little bit about clarity on how they will present. I gave you the atypical presentation, which I see all the time. I'm being facetious. I see people that are extremely fatigued with thyroid storm. They're just dragging. The more classic is the hypothyroid patient. These are the folks that are constipated. They're cold all the time. They're cognitively impaired. They feel slow mentally. They have issues with infertility, with pregnancy, with testosterone production. They have issues with adrenal. They have problems with high LDL cholesterol, energy, sleep, well-being. The list goes on. And the reason is you judge the importance of a hormone by how many receptors are involved in the body, how many tissues have receptors for that hormone. Well, I think thyroid is second only to vitamin D in having the widest distribution of receptors throughout the body. Vitamin D, as we now know, is actually not a vitamin at all. It's a hormone, but it's got ubiquitous receptors. So a little bit about hypothyroid. Yes, edema, the classic non-pitting edema in the legs, meaning when you push in, you don't leave a dent, like the Pillsbury Doughboy commercials for the I'm aging myself. When you push in, it stays. You don't necessarily see that stay. You see swelling, but it's not pitting. Hypothyroid. Hair loss. Hair loss. There's probably not a one of you in the room who has had hair loss who hasn't been told by their beautician or their best friend or somebody, it might be your thyroid. Maybe it's low. Dry skin, constipation, trouble with focus, all of these kinds of things. And then the fertility stuff that I mentioned. Hyperthyroid, yeah, tremor, fast heart rate, loose stool, but fatigue is part of that, which doesn't seem to fit, but it's shared between both diseases. So, symptoms. One of the things that you'll hear a lot about is basal body temperatures. There's really not a lot of data. In fact, I don't know that there's really any data showing that you can get a good idea based on basal body temperatures other than when you're ovulating when it comes to thyroid. It's great for ovulation. Now we've got ovulation kits. You can look at the urine and see exactly when you're ovulating. With thyroid, basal body temperature is not a super great way to valid and predictably say I've got a thyroid issue. Some people will rub iodine on their abdomen and time how long it takes to absorb and try to get an idea of iodine sufficiency as a hallmark of one of the building blocks we're going to talk about for thyroid production. Really not any good data on that as well. So there are some common urban legends out there which really don't pan out in the literature as being valid. Overall signs and symptoms, really enough for you to have for tonight's purposes. Workup. This is where we'll spend a lot of time and I'll get a lot of questions at the end. So I want to give ample time. The way that we were trained in med school and are still trained in med school is that the third generation ultra-sensitive TSH, the first iteration came out, first generation 1970s, around the time Synthroid and levothyroxine were introduced. It was never meant to be used for anything but a very weak diagnostic tool for diagnosing hypothyroid. It was never intended to be used to monitor thyroid therapy. And that's all in medical school we were taught matters. TSH is it. So when you go to your current endocrinologist, primary practice doctors, internal medicine doctors, they'll do TSH. And if you twist their arm, they might do a free T4. They're not going to do a reverse T3, which we're going to talk about, and they're rarely ever going to do a free T3. And they're certainly not going to talk to you about doing antibodies for Hashimoto's. And if they do, they're going to tell you there's nothing you need to do about it. Wait and see, which means wait until you have no gland left, and then you have to get a prescription for the rest of your life because the gland is completely destroyed by your immune system. So there's perceived workup, which is what you're going to be told this is all you need. And there's what's actually out there that actually gives you a complete look of your thyroid. So the labs that you need when you are assessing a thyroid, here they are. You need a TSH, probably the least important of all of them. And I'll tell you why. It's more medical legal stuff in the next section. You need free T3 and you need free T4 and you need antibodies. There's two of them. They're abbreviated. The first one is all caps, TPO, thyroid peroxidase. And the second one is thyro, THYRO, globulin, GLOBULIN, thyroglobulin. Those are both antibodies. They're the two that we look for to diagnose autoimmune Hashimoto's thyroid. Why do I care? Because in functional integrative root cause medicine, we believe that if we see that your immune system is attacking your gland or your cells anywhere in your body, whether it's your ANA, or it's a lupus screening antibody for anti-nuclear antibodies, or anti-thyroid, that's never normal. Your immune system should not go after your own tissue and destroy it. You will be told by traditional practitioners that this happens. It's common. We don't know why. We're just going to watch it, write it down. And as it goes down, you might need thyroid prescription. We want to know about that actually because there's things that can lead to your immune system doing that to you. Chemical toxins, phthalates, parabens, organophosphates, pesticides, BPA plastics, some of these fluorinated things, the Teflon coatings in your skillets, things in the water, heavy metals. Many of these things have been found to trip up the immune system. For some, it might be gluten in your diet, leaky gut, SIBO, these things in our intestinal tract, which take a GI tract that's got normal permeability and is now, you're seeing things, your immune system seeing things that it normally doesn't see. We call that loss of oral tolerance. This is my group that comes in and says, I'm eating chicken breast and quinoa. And a week later, now I can only drink water and I'm not sure that's come down okay. This happens. And there's this orthorexia, right? It's a fear of food. And so what do? They go to their local practitioner who says, fine, go on an elimination diet. Do FODMAP. Do a carbohydrate-specific elimination for however long it takes you to feel better without going after the root cause. The point being, autoimmune thyroiditis, Hashimoto's, it's important to ask for these antibodies because if they're elevated, your immune system, for some reason, is pissed off enough, it's attacking your thyroid. And that is something we want to go find out why. So we focus on gut health. We focus on what food you're eating. Is it the inflammatory standard American crap diet that's pro-inflammatory that raises, in studies, your C-reactive protein for 8 hours? That was a McDonald's Big Mac in that study. And if you eat every 8 hours and you're eating inflammatory food, your CRP, which is a serum marker of inflammation, is chronically elevated. So a lot of us are walking around chronically inflamed. And our immune systems are in the on position and they're stuck there. And they're like this, apprehensive, anxious. When's the next foot going to drop? Living in fear. And so they become hyper responsive. We eventually see this in a lot of people that are genetically predisposed becoming autoimmunity. Okay. This is when you start seeing antibodies. So when you see antibodies like ANA, Hashimoto's antibodies showing up in your system, in general, this is an opportunity of about 10 to 15 years to figure out the root cause before you get diagnosed by a rheumatologist with something. And a lot of times you'll go in along the path and you don't meet enough of the criteria, so nothing is really done until something shows up. Or you can go find the root cause and prevent it in the first place, which is what we're talking about tonight. So nowhere in thyroid medicine is this a bigger deal than autoimmune Hashimoto's thyroiditis. And it's much more common in women. Need I say anything? Look around you who showed up to a thyroid lecture. So it's a big deal. Autoimmunity in general is more common with females than guys. And thyroid is one of the worst as far as that goes. It's our number one autoimmune disease. It's like the canary in the coal mine. It's singing a song before anything else is really calling foul. There's a problem. And we call it a sentinel gland for that reason. It's the first autoimmune disease that usually shows up. So when we see this, we see antibodies, we want to go and find root cause. We're going to look at gut health. We're going to look at toxins. We're going to talk a lot about cortisol, adrenal, because high levels of cortisol and stress are pro-inflammatory and turn that immune music up just as well as toxins or a bad diet. So these areas, these foundational things that you've got to look at when you see these abnormal tests. They're not diagnoses to be an end-all. They're crumbs. These symptoms are clues to following an upstream problem, as opposed to what I was trained to do as a family practitioner, see symptoms as the disease and then play whack-a-mole with drugs. Hit them. No surprise at 65, you're all on 10 prescriptions because I've been playing whack-a-mole with your symptoms instead of doing the hard work of why, which sometimes we can't find, but man, we sure try. Thyroid is one that has huge response, and you can see huge turnaround. So that's Hashimoto's, that's autoimmune thyroiditis. Groves is so rare. If there's people that have questions on hyperthyroid, we can go there more, but it's usually the low end that we're really looking at. So that's a little bit about some of the labs. We talked about antibodies. The one thing you might not have ever heard of before is reverse T3. How many of you heard of that before? It's an unusual critter. We learned about it in school. I didn't know how to use it. We used something called T3 uptake, and I never really fully understood that either. T3 uptake, come to find out, really is not very helpful. My endocrinologist folks don't really look at it very often, and they say at best it might give you an idea as to what's going on with T3, but we really don't fully understand how it works with all the other analytes in a panel. Reverse T3 is very, very interesting, and if I had one PowerPoint behind me, imagine back on the screen behind me, a large thyroid gland at the top of the slide, and an arrow coming straight down from that gland with the letter T and the number 4, T4. And coming from that T4, you have a branch point, a fork in the road. T4 can go one of two ways. It can go to the brake pedal, reverse T3, which is rolling your metabolism, lowering you down. Or it can go to free T3, which is the accelerator. This is pro-thyroid, it's metabolism, it's burning calories, it's making thyroid happen. And there's several things that can determine which path that T4 takes. Chronic inflammation, infection, caloric restriction, toxins, certain medications, things like birth control, certain heart antiarrhythmic medications. There are other prescriptions that are involved there. Toxicity is a huge one. Heavy metals are huge in determining this. Stress, high stress levels can derail which way T4 goes. Why do we even have this system? Who designed that? Well, we need the brake pedal. If we're sick, if we're in the ICU with sepsis, we don't want our metabolism revving. We're trying to survive, conserve energy. I don't want to burn calories. And in fact, we want to put that brake pedal on hard. Reverse T3 goes up and free T3 goes down. Some people get stuck there, and the reverse T3s, when we check them, are higher than optimal. So we're looking for T4 to go to T3. That's your active hormone. And it's really where we talk a lot about optimizing with labs. So in the lab discussion, if there's one thing you walk out of the back door remembering, gland, big arrow, T4 has two ways to go. And there's a bunch of stuff with lifestyle and meds and toxins and chronic infections and inflammation that can determine which way you go, okay? The most important, I feel, lab in a panel for your thyroid is the free T3. Free T3 is what, after all, goes to the nuclei, goes to the cells, and gives the marching orders to the DNA and tells the cell what to do. Burn fat, conserve, work with fertility, upregulate this, downregulate that. It's mediated through that. So when I look at somebody's thyroid labs, I'm looking at a ratio of a number of things. I look at TSH, I look at the free T3 and the free T4 and these antibodies, and I'll look at reverse T3. But then there's some ratios that you'll want to pay attention to. The most important ratio that tells you, are you somebody that is having trouble converting T4 to T3, is just that. Free T3 divided by free T4. And basically you're looking for a number there that is going to give you a optimal level of feeling good, bottom line, from a mental all the way to physical symptomatology. The other ratio that's incredibly important is looking at total T3, which is not a lab I told you to order. It's one we'll sometimes order. And we divide it by reverse T3. And we're looking for a total T3 to reverse T3 somewhere between 6 and 10. That's kind of an ideal number. But I'm often amazed at how many folks aren't converting their T4 to T3. We're told it's a very small number, but when I do the actual ratios and look at these ideal ranges, it's often, no wonder you feel the way you do. This is not normal. And I never would have known that looking at just your TSH and your T4. I just never would have done it. TSH isn't even a thyroid hormone. It's made by your pituitary. So measuring the function of a gland by measuring another gland's product, I mean, intuitively, that just doesn't even sound right. Yes, it's one of the major things that controls production at the thyroid gland of hormone, but there are so many other things that come into play with the negative feedbacks at the level of the pituitary and your thyroid gland. So that's a little bit about the labs, a little bit about the ratios of an appropriate workup, really in contrast to what you might be suggested to have looked at, which is only going to be free T4 and TSH. Medications, including compounds, are confusing. I was told Synthroid has gluten in it. Well, this one's from pigs. Do I get it compounded or do I get it at Albertsons? What do I do? Do I take T4 and T3? Do I need just T4? These are the questions that I get all day long. And bottom line is there's some problems with our thyroid prescription drugs. There's a large group of folks that when they take Synthroid, T4 only, or levothyroxine, T4 only, Tyrosint, which is a cleaned up version of T4 only, they just don't feel well. They've got a lot of symptoms of hypothyroidism. And it's not until you start looking at these ratios of, well, how much of it you're converting to T3 that you actually know they got an issue. So problem number one is that a lot of folks seem to do better on the combination of T4 with T3. Now, T3 is like your high octane fuel. It's way more potent and powerful per microgram than T4. And it's got a very, very short half-life. So there's a lot we can talk about. Do I need sustained release? Do I use immediate release? Do I do twice a day? And I hope someone brings that question up at the end because it's always a good one. But a lot of folks just feel better on the combination. We've got different choices. The regular mainstream pharmacies make Armor. It's from pigs. It's ground up pig thyroid gland. And it's got a lot of different thyroids, not just T3 and T4. It's got T1, T2, T3, T4. We don't really know what T1 and 2 do yet, but we know there's probably something important there. Some people feel better getting glandulars than they do a synthetic T4. There are synthetic combinations. Cytomel, or liothyronine is the generic name, is a T3 prescription synthetic. It's like Synthroid, which is a T4 synthetic. Levothyroxine, T4 only, synthetic. So you combine these synthetic T4s with synthetic T3s to look kind of like what your glandulars are. But those are from animals. That's why they call them glandulars. They're not synthesized in a lab. They're ground up glands. And they mostly are from pigs. So come to find out, where you get your pigs matters. Get your pigs from. There's Southern European pigs where they don't feed them a bunch of glyphosate treated grain. And then there's the ones that they're getting from China and America, which are, who knows what they're getting? Well, we know what they're getting here as far as Roundup, which can cause leaky gut, which can promote autoimmune thyroid. Yeah, so you can see where the root cause. You can make your problem worse by choosing the wrong therapeutic. Um, Synthroid and levothyroxine are not tested for whether or not they have gluten. They have alternate sources, potato, wheat, and several other things that they use to produce those products and bring them to market. So I can't guarantee that when I send my autoimmune thyroid patient to get Synthroid or levothyroxine or Cytomel, the synthetic T3, that they're not getting dosed with glyphosate and Roundup and things like gluten, which we know can cause problems with gut permeability and autoimmunity. That's why one of the first things we do when we find out you've got these antibodies, Hashimoto, in your labs, is we take you off gluten and sometimes dairy, put you on an elimination diet, heal the gut with a gut healing protocol, start working on stress and lowering cortisol because that's pro-inflammatory, and we start the healing process. We don't want to throw things in there that we know with a lot of people can antagonize that whole success. So you've got these options of synthetic versus glandular, T4 only versus combinations of T4 and T3. And there's a few of them that have been found to be very, very clean. I am unashamedly a combo guy. I just find that it works best with most people. Armor doesn't work great for everybody. Not everybody feels good on armor. All of those fixed glandulars, by the way, are a fixed, hardened stone ratio of T4 to T3. It's like an 80-20 ratio, which honestly, human bioidentical is 90-10, T4 to T3. So if you want to get technical about what's bioidentical, human bioidentical, not pig bioidentical, it's a compounding pharmacy where they can do that 90-10. Otherwise, you're stuck with these fixed 80-20 ratios of these glandulars. You can go to a compounding pharmacy and ask something like Thyroid. Thyroid is gluten-free, doesn't have all the binders and fillers that are often destroying our immune system and tripping up our inflammatory response. If you're into T4 only, Thyroid, which is a mainstream pharmacy T4 only product, very, very clean. You don't have near the binders and fillers. Armor's got like 4 different fillers in it, binders, some of which can have gluten, and it's an option. So if I'm looking at a combination product, I'm usually going to go with a compounded Thyroid, which is a 80-20 pig-based glandular, or I'm going to use something called NP, N as in Nancy, P as in Paul, Thyroid, NP Thyroid. And it's something you can get at any mainstream pharmacy. You don't need to go to a compounder like you do the Thyroid. It also is porcine, pig-based, 80-20, T4, T3 combo, but you're going to be able to use your insurance, whereas compounding you can't. It's not necessarily proven that it's going to be gluten-free, but it's cleaner, and they don't have the binders and a lot of the fillers that these others have, like Armor. So my first choice economically for the cleanest product is probably NP Thyroid. You can get it at any pharmacy, 15, 30, 60, 90 milligrams. It comes in milligram doses, not microgram doses, which is how you'll see things like levothyroxine and Synthroid dosed, or Cytomel, the T3 synthetics. So there's a decimal point moved over. That confuses a lot of people. They come in and say, I'm on 0.25. And what that means is basically 25 micrograms. Or you could say 0.25 milligrams. I just hate saying point anything in front of when I say it. It's confusing. So that's a little bit about what's out there. There's compounding, there's mainstream pharmacy, there's T4 only for those that do fine on it, great. And then there's the combination products. You can mix and match. There are conversion tables that all of us that do this kind of work no, you come in on this, we want to go here. We know approximately where we need to go with this product to get you close to where you were. So that's a little bit about the products that are out there. That tends to be a biggie. It's confusing. It's confusing to us. Things change a lot. There were some other products available in the past, Thyroid and things like that, that are harder to get now. The Nature Thyroid used to be mainstream pharmacy and it got pulled. So now you can only get it made through compounders. And now we're really just left with Armor or NP Thyroid from your regular pharmacies where you can actually use your insurance. So that's a little bit about symptoms, signs, a little bit about appropriate lab testing, and a little bit about products.